Think deliberately. Live deliberately. Deliberate documentary.
Robert Brewer is a behavioral healthcare leader and chief clinical officer. He designs systems that support sustainable growth, creating conditions that reduce friction for providers and improve outcomes for the people they serve. Robert, welcome to the show.
Thanks a lot, Quentin. I appreciate the opportunity to be here and looking forward to our discussion.
So, Robert, you've spent more than 25 years building, scaling behavioral health services in environments in community behavioral health. You've worked electronic medical records in leadership direction. But before all of that, I'm curious what first experience was with technology. How old were you? What did it let you do that you couldn't before?
So I guess we're gonna date ourselves a little bit. Some of my first experience with technology, going back to the old school gaming consoles and having access to that. I remember the Super Nintendo and craze that was behind that. You could have your game, for that we were having to go to arcades and playing video games, those kind of things. And so that was probably some of the first exposure that I had. And of course, when we from tapes over to CDs, which are now obsolete, that was probably some of being able to take your music with you and listen to what you wanted to. And of course, it was the period of time when we were over the radio recording songs off the radio. You'd have to stop for and those kind of things. That was probably some of my first exposure to technology, which, has obviously grown very rapidly since then. And we have access to so much things that we couldn't even at that time consider or even think about. So
And what was that experience like for you, having lived through that time of, cassette tapes to DVD to streaming? And more than the realm of music, it certainly technology has integrated across all aspects of our life. And I'm curious what your perspective is on that. How did you experience that rapid growth, and what were the stories being told then as things began to be rolled out, like DVDs, like the first, Blackberries and then iPhones and all that? How did you experience that, and what were those stories like?
So experiencing that was interesting. I look at it now with my children and their access to streaming music and streaming videos and on demand, pretty much everything. As soon as a movie hits, you can basically buy it and you can stream it. And they have no concept of, commercials. They have no concept of waking up early on Saturday morning and running in trying to catch those cartoons that you wanted to watch, because after they were off, they were off. And if you missed, an episode in a series that you were watching, you just were out of luck. Maybe your friends could catch you up or whatnot. I've been watching some different older shows with my son, and we've been watching them through a streaming service that has some commercials. And so experiencing that with him has been interesting, because he's like, well, can't you just fast forward? But you can't fast forward. These services have the commercials built in and baked in, and so he's experiencing that. So seeing that through his eyes has been, fairly interesting. As we saw the progression with things, though, as cassette tapes, when CDs started coming out, and the fact that you could have the stuff on the CD, you had to get a CD player and those things. Of course, they'd get scratched up. You'd have issues with that. And then moving from that, I don't think at the time I ever even considered the idea that you were going to have things on, the iPod and iPod Nano and now, and with we're basically carrying around computers in our hands, in our pockets, that can access anything at any time. So it's been very interesting to me that we now have access to so much information, but yet we still run into a situation where people don't fully understand a lot of things. Behavioral health in general, you still have a lot of stigma in that, with that population and people that don't fully understand it. And on a daily basis, I deal with people in our communities and our stakeholders that don't have a full grasp of exactly what community mental health centers do, or the population that we serve, or the necessity of those services for those individuals that allow them to, have a quality of life or improve their quality of life or build on, what they're already doing, as they work through the recovery, whether that be through mental illness or substance use. So it's been very interesting to see that amount of knowledge accessible, and yet we still have these gaps in our knowledge base.
I think that's a fantastic point. I think we certainly live in a time where there is access to pretty much any information that we could ever think of. We can go find knowledge, have abundant resources and access. I'm curious, from your perspective, what you think contributes to people not experiencing and educating themselves on very relevant works and industries like community behavioral health, for example? What do you think the roadblocks are? How have you experienced that?
Some of that I think is just that it's uncomfortable for some people to have to deal with those topics. And so what I found both through counseling and then, also through leadership and just interacting with people in general, despite the fact that we have access to it, it's still something that's uncomfortable. And people by nature, I think, avoid that discomfort if at all possible. And so when topics are brought up, it makes people a little uncomfortable. And as a result of that discomfort, they tend to shy away from it, or they may ask, the initial questions, polite questions. And then beyond that, they don't really want to dig into, the meat and potatoes of kind of what's happening. I also think there's a pretty significant disconnect between just people in general and their understanding of how prevalent mental illness is, in our population. You have studies that say that 1 in 4 adults are going to experience mental health issues, whether that be depression, anxiety, those kind of things. And that's just the reported numbers. And so we know that those numbers are far higher. We see a pretty significant incidence of substance use disorder, and we see a lot of co-occurring disorders. And I think people would rather just kind of put the blinders on because it allows them to kind of stay in their comfort zone and avoid those topics. And as a result of that, you have a lot of misunderstanding. And of course, we have stigma, and we see that. And but I also think that encourages people like yourself who want to educate. They want to go out and say, okay, yes, this may be an uncomfortable discussion, but there is value in the discussion. And if we can do more of that and utilize the technology that we have such ready access to encourage that education, to, walk people into that so they have a better understanding. Once people understand something, they're more likely to engage with it, and they're more likely to dig deeper and try to fully understand that. And I think that is probably the biggest, both obstacle, but also the biggest opportunity that we have in our current state with technology and access. The information's out there. It's just a matter of packaging it in a manner that individuals can consume, that they feel comfortable with it. And then, of course, through that, you're going to have more understanding, reduction of stigma. It's going to benefit everybody in the situation.
That resonates, and I agree with your perspective, and I want to hear your story as someone who is hands-on and has taken opportunities to have these deliberate conversations and do the work. You've been in behavioral health for 25 years through education counseling at Troy, and then moving through leadership. I want to hear how technology showed up from your journey from paper charts to electronic medical records. What arrived and when?
So for me, when I first went to Troy, I got my undergraduate degree. I actually did a work study in the library, and at that time we were still using microfiche, and we were utilizing the card catalog, and you had the Dewey Decimal System, and so people would come into the library, and we're up in the stacks, and we're pulling books, and putting books back, and those kind of things. And I noticed that during my time there, even over the 4 years there, and I graduated in '94. Went my undergraduate right after that. By the time I had my undergraduate degree, we had a lot more access through the computer. You could come into the computer and you could access that instead of having to go to the stacks or the Dewey Decimal or card catalogs. You could actually go in and search those. That's also a big time when people were starting to have access to these articles. You could go into specific resource libraries and you could access articles, for writing papers and studying and those kind of things. And so started to see that happen there. When I first came to CarePath, which when I first started with them and I actually moved into a full-time position, I initially started as part-time in camp counseling. We were using paper charts. We had only paper charts. You'd have these volumes of charts, and you'd have things like state audits and compliance audits and things like that. And you'd have to transport these charts from point A to point B, whatever that may be, or you'd see these emails coming out. Hey, I need this chart on this individual that's moved in our catchment area from one county to another. Can we have this transferred over? And obviously going in and finding information in those charts was difficult because you may have 10 years of someone's treatment history located in 6 volumes, that were in a chart room. And then, of course, we had to contain those after an individual discharged, and you had a place where you had to store those, and there was a set number of time. And so if you had to go back and pull a chart that had been discharged, that was even more of a barrier. So fast forward from that, I did some substance counseling, and then I was asked by the company to engage in something, a super user for, at the time, our electronic record. And from that, I really enjoyed that and moved into building things in our electronic record. It was ESET. So we were utilizing that. You had these binders of PARMs, the parameters for building in there. And so it was, 20, 30 volumes that you'd have to go through. And so I didn't have a lot of experience with that kind of stuff. So it was kind of, learn as you go. And I kind of learned best by doing something. So that worked out. We then transitioned from that. We attempted to utilize an EHR record. They asked me to come in for implementation. We got that. After about 2 years, we figured out that was not going to be the fit for us. And our CEO contacted Qualifax, which is the vendor that we utilize now for electronic health records, and said, "Hey, we want a demo, but we want the demo from the back end. We don't want to see the polished finished product. We want to see, how does this actually function? If I'm going to build this, how can I do this?" So they obliged us with that. They came in and said, this is how you build forms. This is how you're going to get them to the staff. This is what implementation looks like. We had a fantastic implementation team that came in, and we were able to, within 6 months, move from paper charts in our MI services to staff rolled out and actually using the CareLogic system at that time. Then after that, we got into rolling our substance use services into it, our residential services into it, our case management services, children's services. So with that came, the build. And so I've worked very closely with our management team, and we all came to the table. And I think that was one of the reasons why we were able to be as successful as we have been. Everybody that had a stake in it was able to come to it, so that everybody saw everyone's piece of the pie, if you will, and tried to understand how that connected with the other pieces. And rather, instead of working in a silo or in a vacuum where I'm going to build a form and then finance is going to try to figure out how to make it match up, and, reporting is going to try to figure out how to make that, get the data out. Everybody came to the table and we worked together. And so that model has allowed us to, everybody has a basic understanding of all the pieces. And then, of course, they have their specialties. So from there, we have modified that system. We've gone in and built additional forms, or we've made tweaks to forms that are necessary. We've gathered, staff and clinician input. What is going to make this form work for you? Your boots on the ground, you're actually utilizing this form. How can we modify this so that it meets all the requirements and the standards, but it still allows you to do what you need to do and results in, the individual that's receiving the service actually getting a quality and value-based service. So I think that has been something that we have definitely paid a lot of attention to. And in our training, we have made sure that individuals not only know how to do something. When a clinician comes in and I'm going to train them in CareLogic, I don't want them just to understand the basic navigation. You click here and this happens, or you click here and that happens. Let's talk about how you do it, and then let's talk about why you do it. What is the underlying requirement? What is the underlying goal for doing that? And how is that going to translate into, as a clinician, whether they be a therapist or a case manager or an in-home team, what is the point of doing this? We have these standards. I want you to be aware of these. I want you to understand, the Medicaid requirements and the Alabama Department of Mental Health requirements. But I also want you to understand clinically, why are we doing this? Why are we collecting this information? Why do these specific impact modules have to be provided on this specific schedule? What is the point of having all these components in the note? So that it's not just well, I do this because that's what they said do. There's an investment and a buy-in. I do this because this allows me to provide a value-based service to the individual. And then I can also measure outcomes on the other side. And I'm meeting the requirements, regulatory requirements or compliance requirements. And I think that's probably been the biggest thing that we as an agency have pushed with our clinicians, that education. We want to make sure that we're educating our clinicians on why we do things. And then we're encouraging them to educate our consumers on different things. The expectation is a lot of times that an individual that is dealing with a mental health issue has a full understanding, or that family member of that individual has a full understanding of depression, anxiety, whatever the case may be. when in reality, that's not necessarily the case. And so taking that individual and educating them on, okay, this is why we're doing it this way, or this is the expected outcome, or we want to make sure that you have some input in that process. We want you to have definite input in your treatment plan, but also in your treatment in general. We want feedback on that. How was this session? Is this intervention effective? Is it working? Is it resonating with you? And if it's not, as the clinician, my responsibility then is to say, okay, I need to back up, and I need to do something different. Maybe cognitive behavioral therapy is my bread and butter, but maybe that's not resonating with this individual. And so it's really, I have to then say, okay, what's going to work for this individual? Because ultimately they are the ones that are receiving the treatment, and they are the ones that have the biggest, stake in it. So me saying, oh, I'm going to utilize this because I like this, it doesn't really make sense. And so that has been a lot of what we've done. Now, fast forward past COVID, one of the biggest things we saw was telehealth enter the scene pretty heavily. We had done some telehealth services with our doctors, psychiatrists, but that was pretty much the limit of that. After COVID, we saw the opportunity because the state allowed things that had not been allowed prior to that. And also the technology made itself present and said, okay, here's some things you can do. One of the things that we've utilized very heavily is a platform called MyCare. MyCare is basically iPad based. It's basically like a FaceTime call. What it allows you to do is all of our therapists have a MyCare unit, and they can dial directly to other therapists, but also to what is referred to as a responder unit. Those responder units can then allow for audio video sessions. And so we started utilizing that with our crisis services. We had them in the hospitals in our catchment area. We had them in the jails in our area. And then from there, we realized, hey, this is a real opportunity for us to put these into our outpatient offices. And we can have individuals come in to, say, our Bruton location and see a therapist in our Monroeville location, instead of that individual having to drive, an extra 40 miles, because transportation has always been an obstacle. We're in a rural area. That individual can come in wherever they are able to come in, and then we can provide that same level of service. So after that went very well, we rolled out a true same-day access model. So if an individual calls our access to care department and says, hey, I want an appointment for an intake, instead of telling them, okay, we can get you scheduled 7 to 10 days out, which we felt like was basically telling the individual, we appreciate you that you've mustered up the courage to make this call, and we're going to put it off a week, which tells that person that maybe it's not as important as it is. What we can tell them now in our access to care department, and when they answer those calls, what they tell them is, if you want an appointment today, if you can come into any of our offices, we're going to get you an intake today. If you want to walk in, if you feel like you're in a crisis situation and you want to walk in and see someone, you can walk in today to any of our offices. If we don't have staff at that office that's available because they're with other clients, I've got, 4 other counties, 3 other counties with clinicians. We're on a rotation with those individuals. We go to their schedule because of our electronic health record. That's all very visible. I can connect you with a therapist today. If you don't want to do it today, if you want to come in tomorrow. So the individual then has the opportunity to access those services immediately, which we have found, tends to allow the individual to feel like, okay, these people are actually concerned about what's going on with me, and they're going to provide this service, as needed, instead of, let me schedule you out a week, 10 days, 2 weeks, whatever the case may be. So we've started using that. So we have a same day access. It also allows us to provide significant coverage. If I have an office where an individual's out, they're out sick or they're at a conference or whatnot, I don't have to tell that person we're going to need to reschedule you out a week, a month, whatever the case may be. You can come in, and if you're willing to do, can receive those services via telehealth today. There's no interruption. You don't have to reschedule. We found that the easier you make it for an individual to receive those services, the more likely they're going to come in and actually get them. If you give people okay, we're going to have to reschedule you, there's a tendency for, other things to happen. Life happens. And as a result of that, people don't make those appointments. And then, of course, you see negatives that are associated with that start to happen. And if we can avoid that, which with the MyCare technology and our electronic health record, we can avoid it. It just allows us to make sure those services are being provided when that individual actually needs them. That's kind of where we are right now as far as utilizing technology. So hopefully that answers your question.
It certainly does. And I resonate with the building with the stakeholder at the center, because especially in our line of work, that is critically important and something that was reflected across conversations I've had so far, in that it's so important to get feedback from the boots on the ground when it comes to the clinicians that are out there providing work, and building in a way that streamlines access for people, because that's a large barrier, is the access and the barriers to it. So when we build, the easier that we can make it, the better, and the more that people can consult the service, and that leads to sustainable growth.
Absolutely.
And
Absolutely.
uh,
Prior to that, when we had crisis calls in our local ERs and things like that after hours, we were actually having to have an individual go out to those hospitals, from wherever they were. And, we cover 4 counties. So, and we rotate our clinicians through that on call. So they were having to go out for that. And so the MyCare technology has allowed us to, someone calls in at 2 o'clock from a local ER, that individual can get on the call with them immediately, can access the electronic health record through the laptop, go ahead and pull up that individual's notes, medications, last appointments, etc. Talk to that individual, immediately, make recommendations based on that. I won't say it's perfect by any means, but it is a significant improvement over what we were doing before we had access to those technologies.
absolutely. And I'm curious, with the empowerment that comes from that technology, what can you see now across your operation, whether it be data, patterns, or coordination, that you couldn't have seen beforehand?
So one, I think you have direct access to that individual's chart. You have access to that individual's record. I know when they came into the office last. I know what medications they have taken in the past. I know what programs they've been involved with us in the past. When the last time they came into appointment, if they have a no-show rate that's higher than some others, if maybe that's an indication this individual needs to be moved into a higher level of care based on need, based on the fact that they're having those crisis situations. We can also make those recommendations for acute placement or in-home placement or residential placement quicker, because we have access to that. And it's not a matter of someone calls Friday evening at 6 o'clock and you tell them, okay, I'll have to get back to you on Monday when I have access to the record. Now I can tell that hospital, okay, we've got everything we need. We can go ahead and make this recommendation and start moving toward having that individual where they need to be, instead of basically putting them on pause. So I think that's been a huge boon for our agency. And I also think ultimately, for our consumers, they are now able to get that service as soon as it's needed, rather than having to be told, okay, we really want to help you, but we're going to have to wait until we can get access to all the pieces. And like I said, it's not a perfect system by any means, but I think it has empowered both our clinicians and our agency, and also our consumers and our stakeholders, to have access to those services much quicker than they would have in the past.
Mm. Well, with that being said, we've touched on it a little when it comes to systems not being perfect. Now, you've designed documentation and rolled out systems. I'm curious where you see bottlenecks still. Is it in tools, workflow, training? Where do you see those bottlenecks?
Some of the bottleneck, I think there has to be that buy-in. So adoption seems to be a bit of a bottleneck. I think that it's important that the individual that is taking that information has an understanding of the background requirements that are needed, but they also have a clinical understanding of how is this going to fold into allowing this individual to utilize this tool. Because it's like any other tool. If an individual does not fully understand how to utilize the tool, or if they don't feel like there's value in the tool, they're more likely not to use the tool. And so one of the things that I think our agency has tried to do is make sure that, just like we did with the initial training, it's not just a matter of, okay, why do you have to do this? Because of course you can say this is policy, this is a requirement, those kind of things. And I understand agencies have to function that way. We have to say, okay, these are things that have to be done, and that's fine. I think you also have to say, okay, why are we doing this? What is the expected outcome? Just like with anything else that we do, why is it that I need to do this, and what's supposed to happen, and how will I know if it was useful to me? So discussing with those clinicians, why is it necessary for me to use evidence-based practices? Why have I folded, research-based, CBT or solution-focused or motivational interviewing into our progress note? it makes the note larger. You know, you have to learn it. It's new. It's novel. But what's the point? And it can't just be, you know, that old school because I said so, because that never lands well. It needs to be, this is what has to happen, but this is why it has to happen. And I think if you train that and you discuss that and you educate the individual that are using it to the degree that you need to, then they can take that to the consumer and say, this is why we have to ask these questions. You know, this is a standard of care, and that's why I'm asking you the same questions through the mental status exam every time that I see you. This is why I'm touching on things like suicidal ideation, homicidal ideation every time that I see you, even though you don't have a history of it, because the standard of care says that I need to ask those questions and I need to gauge. You know, this is why I'm applying a PHQ-9 for depression to you every 2 weeks, every month, whatever the case may be, even though you don't necessarily have a depression diagnosis. If one starts to develop, I want to be aware of it early, and I also want to be able to track those trends. One story that I use in some of the training, I had an individual that came in that was very resistant to talking to our doctor. Period. This individual was dealing with depression. It came in. I said, that's fine. Let's do 6 weeks. I'm doing the PHQ-9. Scores are high. They continue to be high. Went to the individual and I said, hey, you know, your scores are continuing to be high. I feel like monotherapy alone is not sufficient. You know, would you consider? Was able to pull up on the dashboard, show this individual, look, these are the scores. This is what's happening per your report. Here's where you are. Was willing to go and talk to the doctor, you know, got on a medication regimen and started to see a decrease in those scores, and then was able to discharge and, you know, go on and do things that individual wanted to do. And it was much easier for me to discuss that with them because I had something tangible that I could say, look, this is the scores. You know, here are the trends that we're seeing. And I feel like this may be the time to go ahead. I'm not going to force that. I'm not saying you have to. This is just a recommendation, but here's the data that I'm using to make that recommendation. Not just I have a hunch or I think this is what we should do, but there's actually something that's showing me, hey, this alone is not sufficient. And so I feel like that a lot of times that kind of takes hold when you're providing that training and people say, okay, there is value in it. And like I've said before, I think that if people see the value in something, then they're much more likely to utilize it. You know, they have to be shown that it's actually a useful component. Otherwise, they say, well, you know, this is infringing on my clinical discretion. It's stopping me from doing the things that I feel like I need to do with my consumer, you know, or like you said, it's a bottleneck. It's not a bottleneck. It's a tool that can be utilized that can allow you to do the things that we're already doing anyway. You know, I'm just trying to, or the agency is just trying to better equip you, you know, to deal with those issues. So I think that's probably one of the issues that we have. And then of course, you know, technology in general, it's constantly changing. There are tweaks that have to be made to, you know, the stuff that we're utilizing. We have to get policies that line up with that. And a lot of times people don't have a full understanding of why have we made the transition, and they're not necessarily taking into consideration that it was not just we just decided to make a huge change. There are all these components that led to it. And, you know, again, I think that just circles back to the concept of you have to educate, you know, why are we doing this? And also, how do we do it? And if you can connect both of those things, then obviously people are going to do a lot better with it. So,
yeah, and I think that your sentiment on using the data to make it tangible for the people that we serve is one of the most powerful use cases of technology, especially advanced technology, that makes it so much easier to produce tangible data that can drive data-driven decisions. And so one of the things that we had discussed was we have access to so much data now, but it
right.
isn't always utilized the way that it should be. You've spoken on it where it comes to, you know, buy-in of like using that data and using these tools, and you spoke to that being utilizing it the way that it should be is being able to gather that data in an organized way and then present it in a way that is tangible for the clinicians, saying, here's how we do this, here's what it does as well, like here's what we're able to produce, and here's why we do it. I'm curious if well, when it specifically comes to documentation, because I think that is one of the biggest drivers of burnout. When we are rolling out these tools, what part of the clinician's journey, specifically with documentation, do we build to protect them, to make their day easier? Is documentation one of the primary tools that we are looking to optimize for our clinicians? Are there others?
I think definitely that is one of the things that we're looking to optimize. And I look back through our electronic clinical record, and we probably have 35 revisions to our progress note, our basic progress note. And the reason for that is that input from the individuals that are actually using it. What would make this easier? How can I turn this into something that allows us to gather the information, but to do it in such a way that it's fluid and it flows for that individual and the consumer and everyone that's involved, but still meets the requirements that obviously we're going to be held to. There's specific standards that have to be met. I think that you have to have that marriage of meeting requirements, but also making it as fluid for the individual, as useful to the individual, both the consumer and the clinician, as possible. And so that's one of the things that I think that we try to do with our progress note is make sure that there are components in there that are showing that value. How can I make it so that logic is built in so that if specific questions are answered in specific ways, other information pops up for them. But if they're not answered in that way, it doesn't clutter up. It's not just something I have to go through just to be going through it. And so that's something that we've done as we've moved as a center toward evidence-based practices. That has been something that we've been working pretty diligently on, is trying to make sure that we fold those evidence-based practices into the progress note in such a manner that the individuals can access them and utilize them. And if they're not something they're going to utilize, they can just go to another screen and they can utilize what's available. So if we're going to utilize cognitive behavioral therapy, if an individual wants to use cognitive restructuring or SMART goals with that, they have the ability to click that and it opens up information for them. With our intake, we were looking at our intake and we were seeing situations where we were meeting all the requirements for the state, but it wasn't necessarily giving the clinician a clear idea of how can I rule out specific diagnosis or add them in. Obviously, they have access to the DSM, and we know that, and that's the standard we're going to utilize. So what we did was polled the staff. What are the 10 most prevalent diagnoses that we're seeing? We took those, took the DSM-5 criteria, folded them in. If an individual clicks and says, hey, I'm thinking depression, they click on depression, it opens the symptoms, it opens the criteria, and it tells that individual on that intake, if these are not met, this is not it. If you click on anxiety, the same thing's going to happen. If you click on oppositional defiant, those things are going to open up. So the individual has the DSM-5 to refer to, which is, that's what we want them to do. But they also have that quick guide that almost pops up in the intake that allows them to say, okay, this is why I'm thinking what I'm thinking. And then, of course, when they go to develop that diagnosis, they can take that information from that intake and they can fold it right in. And so those individuals feel supported, but they also are allowed to build that confidence. I'm starting to see this. We hire a lot of very new clinicians. Community mental health centers in general hire a lot of, straight out of college, they've just gotten their degree, they're going to pursue licensure and those kind of things. So they've had classes, but this real world exposure is going to be different. And so giving them those tools so that they do build that clinical confidence and they do feel that they can develop those clinical skills, it goes a long way. And then that individual does not feel stressed about it. They don't feel like they're not going to get it right because they have access to it. It builds their confidence and it also builds their competence in the field. And then, of course, when you sit across from a clinician that has those things, as a consumer, you're going to feel better about the situation, and so you're going to engage more readily. You're going to do, the things that need to happen to develop that rapport and to have that relationship. And that's, so again, everything comes back full circle. And I think it's through that education and that support of everybody at every level in the process.
Mm-hmm. Yeah, I agree in that the education and the tools and explaining the how, what, why we are using the tools can be very empowering, especially exactly as you said, for people that are entering the field. They're building their confidence, building their competence. Now, with the rapid advancement of tools, AI particularly is arriving in intake, documentation, triage, measurement. From where you sit, what's real today? How can that be utilized? And what can it become going forward?
So, AI in general in the behavioral health field, I know that it has a presence. I know that it's going to continue to have a presence. Our agency has been hesitant to jump directly into AI, and the reason for that, I think, goes back to what we were talking about earlier. With a lot of our clinicians are brand new, and the AI technology that is available for assisting with notes and those kind of things, it allows individuals to write these beautiful notes that refer back to specific interventions and what was done and those kind of things. We want to make sure that the individual has a solid foundational understanding of those things before they utilize AI.
Hmm.
AI can go in and say, I heard specific words, and so my assumption is, through uh, the process that I have, is that you were going this way. We're going to look at pattern recognition, and the assumption is that this is what was happening, right? And that's what's happening. If the individual does not have a full, foundational understanding of those concepts, though, you may have a disconnect. Is my concern. Where the note looks like these things happened, but the individual did not fully understand those interventions and was not applying them to that degree, and so there's going to be a disconnect between the author and the note, and there's also going to be a disconnect between the individual receiving the service and what the service reflects. And I will say I don't have a lot of experience with AI note taking. We are not currently utilizing that here, and I'm sure there are products and my concern is, are we going to make sure that we are protecting those individuals and making sure that they are, acclimated to the use of the tool, like anything else, before they're just kind of tossed into it. And so I think that's some of our hesitancy, with utilizing AI note taking and those kind of things, at least in this agency.
Resonant. And you've trained generation of staff into the systems that are currently in place. And so we're talking a bit about what will this technology look like? What does it look like? What do you want to see? And what matters? And what do we protect as the tools change?
I think, that's an excellent question. I think one of the things that we have to protect is, again, that foundational understanding of what we do.
Mhm.
And I think a lot of that comes through making sure that you have individuals who have a hunger and a desire to continue learning. I think when individuals stop learning, that's when problems start. There is always new information, there are always new interventions, there's always new ways to look at something. And I think being open-minded and saying, okay, I'm willing to, look at this and hear this viewpoint and see how this can, be folded in. And then having a management team and an administrative organization, portion of the organization that says, hey, we want to make sure that we fold these pieces in, but we want to fold them in right. I'm not just going to dump it in there because it's something that's out there. I want to see how it works. I want to see why it works. And then I want to come back and check on that in 90 days and 6 months and whatever the case may be, and make sure that it's doing what it's supposed to be doing. Is it adopted as it should be? Are we avoiding those workarounds and things like that? So I definitely, I think that's something that we have to protect, because ultimately we have to make sure that the individuals that are receiving services, if they sit down with me as a therapist and I say, these are my credentials and this is my experience and I'm going to be providing your service, then I need to be the one that's providing that service. I can utilize whatever tools are available, and that's great as long as I understand those tools. But ultimately, I want to make sure that I'm providing that service to that individual, and they're getting what they signed up for. Now, as far as where I'd like to see it go and where I see it going in our agency, I think that telehealth in general is here to stay, and I think there's a lot of opportunity, especially with a CMHC like us. We're in a rural area. The ability to have that same day access was great. Now, expanding on that, what can we do? Can we put these units in our high risk consumers' hands so that they have on demand service access? And I absolutely think that we can. Can we expand that into intensive outpatient groups that individuals can log into from wherever they are and access? And we have to make sure that we protect HIPAA. Obviously, we have to make sure that we protect that individual's access. We have to make sure that they're getting what they signed up for. But at the same time, that technology allows individuals in a rural area and individuals who have transportation, obstacles and those kind of things to still access those services. And so, when I look forward in our agency, what I see us doing is expanding on that. We have that foundational understanding. We know what works and what doesn't in our outpatient offices and some of the other settings, our stakeholders, hospitals, jails, those kind of things. What else can we do with that? Because having an individual have access to a therapist when they need that individual, and it's their therapist and they can connect with that individual, that's going to be huge. And you're going to see decreased no-show rates. You're going to see increased engagement and adoption, and you're going to see outcomes that show this individual is actually making progress toward whatever goals they've set in their recovery journey.
Yes, and I resonate with that vision of realistically, what can we see when we picture this going well, right? Like giving people access in an even more streamlined way, creating groups that people can connect to. All of that is really important, but you also bring up a really important point, which is protection, safety, which is a huge conversation topic that's going on right now in the world of AI, in the world of technology, is
Right.
how to innovate safely, how to integrate safely. And so what does that look like from your perspective when it comes to developing, innovating, and integrating technology in a way that is regulated and safe for the people that we provide services to, where at the end of the day, it's PHI, it's information that is sensitive and personal, which is a huge trademark of our profession, is protecting people's information that way,
Right.
being diligent and deliberate.
And I think one of the biggest things that we have to do with that is make sure that just because new technology hits, you don't feel like, okay, if I don't immediately incorporate this into my current workflow or process, I'm behind. I think that there's nothing wrong with, innovation. I think there's nothing wrong with progress. I mean, the access to these tools has allowed us to do things that we weren't even considering, 10, 20 years ago. At the same time, though, you have to fold it in and you have to integrate it using those guidelines, the guardrails, if you will. You have to make sure that you're looking at the different pieces. And I think that comes from fully understanding what the technology can do and also what the technology cannot do, where the issues there are. And then also making sure that the individuals that are using the technology fully understand those elements and why we're doing it and what the shortcomings are, if there are shortcomings, and what the possible pitfalls are. And then making sure that the clinicians in that case, that they're making sure that they communicate that to the individual that's receiving the service. Here are the parameters. This is what it can do and what it can't do. This is what the expectation is, and I need that feedback. And I think that feedback loop has to run from administration to consumer and from consumer back to administration. We have to be careful that we don't engage in what I see as a huge disconnect. A lot of times you have people that are providing services that they have their finger on the pulse, if you will, right? And then you have people that maybe have not provided services in a while or have not provided services ever because their role is administrative. You have to make sure that they fully understand all of the components and vice versa. One of the things that here at the agents that we make sure we try to do is people understand that disconnect. Admin has a role, but they cannot function without the staff. Staff has a role, but they cannot function without admin. And ultimately, neither of us can function without the consumer.
Mm-hmm.
And so as long as we keep that in the forefront of what we're doing, I think that allows us to, take a step back and look at it. This looks beautiful on paper. Can it be utilized in the capacity that we want to utilize it? And if it can, does it improve things, or does it make more difficulties or more obstacles, or are there shortcomings that we didn't necessarily see? And if we get that feedback loop, even though we've invested time in it, are we willing to sit down and say, you know what, we need to readjust, we need to back up and punt, if you will, because this is not working. It's not doing what we thought it was going to do. So how can we either salvage it, or what's the other option? And so I think that sometimes, even though that's very difficult to do, it's very necessary to do.
And when it comes to, having these deliberations that are difficult, that are multifaceted, and the goal is bringing synergy through collaboration and feedback loops, how do we organize that on top of providing the services and dealing with the reality of the dynamic shifting nature of the world that we live in? With technology specifically, there's lots of talk of regulation, and that's an ongoing deliberation, discussion, debate at this point of how can we regulate, how can we, because there are many firms out there that push against regulation and push with that model of innovation in mind. But I agree with you in that if we're going to go about this, it has to be in a way that instills feedback loops and requires, deliberate, documented discussions of these complex issues, and all of that takes time. So how can we move that needle and push this ethical, regulated implementation forward?
Well, I think it's an excellent question. That's probably, sums up some of the biggest difficulties that this field is experiencing right now. A while back, our management team, our CEO, said, "Hey, I want you guys to read this book. It's Good to Great, Jim Collins, right?" And one of the things that stood out to me the most from that book was the concept of the bus. He talks about the bus, and he talks about the fact that you have the seats on the bus and you let the people on. And but the thing that stood out to me the most about that analogy was he would basically, hammered home over and over again, you may have the right people on the bus, but they may be in the wrong seats. And you have to be willing to say, you know what, I need to move you to a seat that it better allows you to do the things that you're capable of doing. And so I think one of the biggest things that we have to do is be aware of the individuals that need to be moved around in those positions. You need to have, that, like we talked about, that feedback loop, but how can they provide the most value? Because I may go in and look at something and say, okay, this is exactly how it should function. An individual who's providing that service on a daily basis may say, yes, but that's going to cause significant pain points. It's going to cause significant friction, and that's going to result in issues. Maybe I had not considered those issues. And so maybe I need to be able to say, you know what, let's pull you onto the bus, using the analogy, and let's see what that feedback looks like. And then from there, the willingness to say, okay, this is not my idea, it's someone else's idea, but it's a good idea. And so I need to go ahead and make sure that we roll this, because this is going to allow us to do what we're wanting to do. The ultimate goal is that we are providing the value-based service to the individual, and that they're getting what they need to move in that recovery journey, whatever that looks like for them. We can't get so locked in on this is the way it has to be that we forget what the point was, right? And I think that's, if we have that open mind and we're willing to say, okay, I need to utilize these resources that I have, sometimes they're very limited resources. How can I leverage them the best that I can to make sure that I'm moving toward the end goal, which is, making sure the individual receives the services, making sure the individual receives the services and benefits from the services. And so I think you have to have, that humility to step in and say, this is what I think, but I'm open to, with new information, to change that way of thinking if it's going to benefit everyone. And I think if the consumer benefits, we all benefit. And so, that's mentality that I think we have to take into everything, every decision that we make. As we're establishing new processes, of course, it's great if they just flow perfectly. Realistically, mental health services in general, behavioral health, it just doesn't happen that way. They don't. It's never a first try and you nail it. And you have to come back and say, I'm going to invest the time and the effort necessary to make sure that we revise this as appropriate based on the feedback. We talk about evidence-based, we talk about outcome measures. The state of Alabama is moving heavily toward that, where CCBHC is on everybody's, this topic of discussion. A lot of that is that outcomes measures. And I think that we take that mentality and we apply it to everything that we're doing anyway. If this process is not doing what we want it to do, that's an outcome measure, right? And what it tells us is we need to go back and we need to revise that. And we need to make sure that, we now consider this other issue that we had not considered before. And then, of course, we should see an increase, an upward trend in our outcomes measures, which is what we want. We want to see people getting what they need, and feeling better, being able to move down that journey of recovery in the best way that they can. And we want to make sure we're supporting those people.
Something that you spoke to that I think is integral in being able to navigate this climate effectively and implement change in a way that is grounded in feedback and that can empower people is humility. Humility, particularly paired with the openness and the curiosity to learn more, to be able to say, I don't have all the answers, but I am grounded in these principles, and we have a systematic approach about going about this. We have tools that we can use and that we can install to go about this iteratively, like in a incremental way.
Right.
What have you experienced that has taught that humility over the years? You spoke to it some about the experiences of, trying to roll things out and it doesn't always go the way that you planned. How has that lesson become a through line throughout your career? Humility.
Yeah, I think that for me, some of that is the fact that, our management team in general, administrative level, that's modeled behavior. That's something that I've seen modeled from the time that I've started here with individuals that, my direct supervisors, moving on up through the chain have modeled that behavior. If something's not working, then even though I'm invested in, even though it's something that I want to work, then I'm willing to go in and say, okay, show me what we could do to make it better. And so something that has, kind of stuck with me throughout my journey through my career has been, you're going to do the best you can. You're going to take all the information that you have. You're going to, optimize a process. You're going to put something into place. And then you need to take that to the individuals that are actually going to utilize it. And you're going to say, okay, I had this initial feedback. This is what we have. Tell me where you can break it. Show me where there's pain points. Show me where there's gaps. What do you like? What do you dislike? I don't think that I've ever been involved in a staffing that I've not said, if something's not working, let's talk about it. If you've got a suggestion on how to make this better, let's talk about it. And so that I can then take that back to the management table. I can take that back to the individuals that are going to, have ownership of those processes and say, this part's working, this part's not working. What are we going to do about it? One of the ways that I've seen that model, we attempted to roll out an electronic health record prior to Qualifax and CareLogic, and we invested a lot of time and a lot of effort into that, and it was not working. It was just not going to be what we needed. It was not going to fit our, what the staff needed to do. It was going to be cumbersome. It just did not allow us to do what we wanted to do. And so, for the CEO to come in and say, we're stopping on this. I understand we've invested X amount of hours into it. it's not working. What can we do different? And then to bring in another company and say, basically we want to start over, you know, and that went really well because this product actually met the needs that we had. And while I don't think any program is perfect, Qualifax and their product CareLogic has given us what we needed to do the job that we needed to do. And so that humility to come in and say, this was a failed effort. We learned a lot from it. And we took that. And I think that's one of the big things is, even when you're doing something and it doesn't work out, I feel like you gain experience from that. And there are always pieces that you can salvage, if you're willing to. I think you can get caught up in well, this didn't work out and I'm going to be upset about it. Or you can say, okay, this was an opportunity to learn these things. How can I use these learning points in my next project? And if you do that, then it doesn't feel wasted. And if it doesn't feel wasted, then a lot of times people are able to kind of, get back into it. And we transitioned from that, that failed attempt into this new implementation, and everybody was focused and everybody was ready to get the job done. And it worked out really well. And we rolled out in about 6 months. And a lot of that was due to the fact that we had learned a massive amount through the failure that preceded that. And so I think that ties back into that too. I try not to ever walk into a room and think I know everything about everything. I know the things that I know, but I'm willing to adjust those beliefs based on new information. And if you can show me a better way to do something, and you can show me that it is actually better and that there's benefit to it, then hey, I want to incorporate that. And I think that goes back to what we were talking about earlier. You have to be able to have that desire to continue learning. As you've noted on, throughout this discussion, things are changing very rapidly. And you can't just say, well, this is the way we've always done it. This is the way we're always going to do it. But I do think you have to say, okay, show me that it's better. Show me that it brings value. And if it doesn't, then what pieces might I incorporate, but not necessarily the whole thing. And so just that open-mindedness, I think that, being able to say, I want this to be the best that it can be, regardless of who has the answers, is probably the biggest thing that we try to apply on a daily basis here.
With the dynamic environment and realities that happen when it comes to technology, we have self-driving cars, we're building these big data centers, they want to build them in space, all that stuff. What are you excited, hopeful, and optimistic about with the future of technology and what it's going to look like?
So I think that probably I am most excited about the fact that we do have access to all of this information. And if we can, like we talked about earlier, if we can package it in such a way that people are willing to access it, willing to learn that, I think that's going to go a long way towards reducing stigma that's associated in behavioral health, to encouraging people to find out where they fit in, to assist with those situations, to allow people to support one another, regardless of where they are in that, whether it be the individual who's actually experiencing mental health issues or substance use disorders, whether it be the family member of that person, or just the community in general, or the provider. And so I think my biggest excitement about that is eventually we're going to get to the point where, because of the variety of access that we have, people are going to access this information. And from there, people are going to have a better understanding, and that's going to benefit the entire field. Through that benefit, we're going to do a better job. We're the helping profession, right? That's what we do. So I feel like it gives us access to avenues of helping our communities and our consumers and ourselves that we've never had access to before. That's probably the thing that I am most excited about.
Well, Robert, thank you so much for taking the time. Thank you for the discussion. I learned so much. I sincerely appreciate the opportunity. I look forward to staying connected, seeing how things progress and how we as leaders can navigate change in a way that benefits our industry and benefits the people that we serve.
Quentin, it's been my pleasure. I've enjoyed it, and definitely want to make sure that we stay connected. And if there's anything I can do in the future going forward, don't hesitate to let me know.
Thank you.